we had to start because we were already 15 minutes late. So we're joined by the convener and the co-chairman for the session, which is pretty good. We're just waiting for Satanshu sir to load his presentation, and he'll start on time. I was supposed to be the first speaker, but I've not even prepared my slides, so I'll forego. Kavita seems to be the only one ready. So we are welcoming you onto the rostrum with a huge round of applause, Dr. Kavita. It just doesn't stop for you, see?
I have to state, put a disclaimer at the outset that my topic is pediatric cataract, and I am not a pediatric ophthalmologist. In my hospital, we don't really have any department as such. We have part-timers who come and go. So I do a few cases, in fact, but I don't claim to be any expert on that. Whatever is my limited knowledge, I will share about that. So I think when we are doing pediatric cataract surgery, there are, can I have the slides moving, please? It's not moving. Yeah. So the few questions to answer are that is surgery needed or not needed? Is an intraocular lens needs to be put or not? Surgical technique, what technique we are choosing? The intraocular power calculation, and of course not to forget that, that the job does not stop with surgery but post-operative management. So to operate or not operate, I think if the cataract is like this, where it is not in the central visual axis, or it's not enough to cause any visual problems, or it's a blue dot cataract where we know that it doesn't really impact the vision too much, so then we do not, we can observe this child and look at the vision. Now, what are the indications for early surgery? Like in which are the cases that you are going to operate? Obviously, if there is a total cataract, if it's a unilateral cataract, if it's an asymmetrical cataract, because that's also going to cause amblyopia, and if you're seeing secondary effects like strabismus, nystagmus, or if it's an older child, if you can see the vision, if the vision is less than 6/18, then he's having concomitant strabismus, nystagmus, I think these would be indications for early surgery. Now, putting an intraocular lens or not, like I mentioned, most of the patients I've done have been about 24 months. If the child is lesser than 24 months, there is going to be a lot of myopic shift and refractive, error, calculation errors. So if you're going to put it in an infant, I think for certain prerequisites which need to be fulfilled. The corneal diameter needs to be more than 10 millimeters. Axial length needs to be more than 16 millimeters. Normal intraocular pressure and an absent angle anomalies. When you're calculating the IOL power, the rule of 7 for above 2 years, age plus target hyperopia is 7. So if you are going to operate, if you're going to, if it's a child is a 2-year-old, then you're going to aim for 5 diopters of target hyperopia. Now again in infants, like I said, I don't have any first-hand knowledge, but this is how literature reports that if it's lesser than, around less than 6 months, then around 3 to 7 diopters. So as you can see, it's very vague, like, the recommendations, it's around 6 to 8 diopters is what the infant aphakia study shows. Now surgical techniques, 2 techniques, either lens aspiration with primary posterior capsulorhexis with anterior vitrectomy. The PCC and anterior vitrectomy is mandatory in the younger kids because who are not going to be able, you're not going to be able to do an ND-YAG, because I think the PCO rates, as we know, is almost 100%, or you can, in the younger kids, or especially congenital, like rubella cataracts, where the cataract's very friable, where you're going, in infants, you may need to do a lensectomy with an anterior vitrectomy approach. So this is my, I'll just show a video. So this anterior capsulorhexis, I think it is very different from doing in an adult. Once you make the initial nick, the pediatric rhexis forceps really helps. You have to grip and re-grip, and after using a nice viscoelastic in the anterior chamber, keep re-gripping. In you see towards the end of this video that in spite of doing that, there is a point where it is actually trying to run through the periphery, but it's important to stay cool and refill the eye if possible. and go ahead and complete your rexes. So this is the point where it's now going to try and start, running out a little bit, and but you can go ahead and salvage the situation. So this is a most important step here. You can see it's running out a little bit, and you can keep pulling towards the center and salvage the situation. So next would be, next is pretty much just you go ahead and remove your viscoelastic and do a lens aspiration. There is not much to that. After your lens aspiration is done, because not much, I'll just move to the next video. What is important is your posterior, what's important is your posterior capsular rexes. Here also the initial nick, you make it with your 26 gauge needle, and then use your the rexes forceps and go ahead and complete your posterior capsular rexes. I also do an anterior vitrectomy. Here you make that nick. Can we forward the video in any way? Yeah, so you go use an anterior vitrectomy and also do a limited anterior vitrectomy, and then you can place the IOL either in the bag or 3-piece IOL, whichever IOL. Here I'm going to place a single piece IOL. You can keep it small and limited, don't have to make it really large, so that it's easier to do your in the bag placement. Again, similar steps, just like your anterior, you go back, grip, regrip, and complete your rexes. I think I'll move forward in interest of time. What happens once the surgery is over, and at the end of surgery always take a suture, in these cases. Obviously if it's an infant, you're going to give the glasses. Make sure you're giving glasses along with bifocals, and amblyopia management in IOP monitoring is very, very important. Because I've been a cornea surgeon, I have to talk about this. So these are the cases, pediatric cataracts are the cases where you may aim at doing a primary or an early cataract surgery. Otherwise, typically we wait for 3 months after suture removal. So this was a patient where it was a child, and this was how they came, with a ruptured anterior capsule, and we took the other eye intraocular calculations, and we went ahead with doing a primary intraocular lens implantation, because we didn't want to subject the child to another anesthesia, and obviously the capsule was ruptured. This is another patient with a very extensive corneal tear, where you can see the sutures are in, and we have not removed the sutures, and the ruptured anterior capsule, where I've done the lens aspiration, and I'm going to now place the intraocular lens. And this is I used a 3-piece IOL, because obviously there is no rexes. This is how the patient looked at the end of removing sutures, and the patient gained 6/6 vision. So thank you so much.
But I tell you what, if you make presentations like that and you put forward a disclaimer that you're not a pediatric ophthalmologist, we're going to turn a lot of pediatric ophthalmologists jealous of you the next time they would walk into the podium to speak on something. Just one question before I invite the panel or the audience for shooting questions at you. Since you mentioned that you would be waiting for some time if there's a corneal tear that's coexistent, would you always do that, or would you restrict yourself to cases where the anterior lens capsule is not ruptured along with the cornea?
So if the anterior lens capsule is not ruptured, if we are not going to do any retinal intervention, if there's no hemorrhage, RD and all of that, and if it's an adult, then I would definitely wait, unless it's getting intumescent, causing problems with the chamber. In an adult, for sure, I would wait for 3 months, get the sutures out, stabilize the corneal topography, and then go ahead with doing an intraocular lens placement. But if the capsule is ruptured in an adult, then at the same time, I would probably just do a lens aspiration, but not an IOL implantation. But because these were kids, we didn't want to subject them to again another, and just use the other eye for doing the IOL placement.
So you would do it in the primary setting itself?
I did it in these 2 cases, yes.
Right. And when you plan it after suture removal, if you find that the opacity, the scar that's resultant of the corneal tear is bisecting the pupillary area.
Which was, it did, like you saw in that case,
yeah. So I'm just asking you, if it's bisecting the pupillary area, so there's very little area of the visual axis left clear, would you consider an iridectomy after putting in the IOL, just to increase the window through which the light transmission would take place? Would you consider that?
That's a good suggestion, though I haven't really done that. This child, I did refractive, after I did refraction, initially she was 6/12, but over a period of 1 year, with a good amblyopia management, she did come to 6/6. But I think your point is very valid. If the scar you feel is denser, then yes, that would be a great suggestion to, implement.
Any other questions for her? Anything from the audience? Any points?
No, I get a few points for going first also.
Absolutely. You
Thank you.
deserve another round of applause for that.
Thank you so
Kavita.
much.
Thank you so much for accepting the request. So in comes Dr. Satanshu Mathur, absolutely needs, sorry? Okay, fine, sir. So Dr. Satanshu Mathur is going to speak to us on IOL explantation made easy. Is, as we all know, from which part of India he belongs to. So the next 7 minutes are yours.
Thank
Sir,
you,
please
thank you,
carry.
Anurag, third chairpersons. Match is going interesting, so we have to leave early. So everybody. So good afternoon, everybody. After lunch, this thing, the IOL explantation has become very important nowadays. In our, when we have started practice, patient has having 3 or 4 diopter syndical power. It was not so important for us. But stop, hello. But it was not so important for us. We used to give glasses. But now, scenery has changed. Everybody wants 6 by 6. So things have changed. So we have to change our mindset also. There are many indications for IOL exchange. These are indications for IOL exchange. Wrong IOL power calculation, unhappy patient, especially after the multifocal and trifocal. Poor positioning of the lens because of insufficient capsule support, damage to IOL optic haptic. That can be the chances of and IOL exchange. This is a case, very clean case operated by one of my colleagues in neighboring city who came to me with a +4 diopter refractor and other eye was 6 by 6. So patient was not happy. I have also advised him to use the glasses, but he was not happy. So I thought, he has came from the other doctor to me, he will came from me to other doctor. So why can't we do the same thing which is required? You can have a piggyback lens in this also, but at that time we were not doing the piggyback. So we have tried to do the explantation of the lens with new IOL. So it was case operated very recently. So there was no adhesions. We could easily take out the lens from the bag into the anterior chamber. You have to use copious amount of viscoelastic because you have to protect the posterior capsule and the endothelium both. So in this case, there was no difficulty because case was very good operated by, it was his bad luck that power wrongly calculated. And most of the time the wrong power calculation happens when there is a patient either high myopic or high hypermetropic. So once the lens is in the antechamber, we are injecting viscoelastic to protect. This is a simple cut, scissor cutter, lens cutter forceps, scissor. Easily available in market, made by Indian companies, not very costly. You can take out the lens in many ways. Our main aim is not to enlarge the incision. Incision should be 2.2 or 2.8 millimeter. This is the 2.2 millimeter incision was there, from which the scissor has gone. We have rotated the lens and we are going to make a triangle cut. You can make triangle cut, you can make single cut. We show on the 3 videos, different types of cut you can make and take it out the lens. So we are rotating. When initially we used to make this triangle, now we are simple giving a single cut and lens is coming out. Aim is that this scissor, when scissor is entering, it is 2.2 millimeter incision. So it is cutting again and triangle is formed. Now we are enlarging incision to 2.8 millimeter to expand the lens. So we have stitch test surgery, and that's why this lens cutting scissors are used. First, this small part is removed. Now the triangle part is saved. Rotate it. Again, injective viscoelastic. Hold the lens and pull it out. This serrated forceps, simple forceps available in every OT. Just hold it and take it out the nucleus by rotation. So you can remove this easily. So I am just cutting it short because lens implantation is not so important. Next video chala jana. Next. Ise band kar do. So this was the one. Second is the case another indication of IO explantation, and that is number 2. Number 2, upar wala. Number 2, this is another indication, opaque lens. I don't know, for last 2 or 3 years, we are getting so many these opaque lenses operated by our senior surgeons. Or you must be also having, this patient has vision 6 by 36, patient was not happy. So we have no option but to remove the lens. This was operated almost 20 years back. Lot of adhesions are there. You can see when we remove the lens, you can see the capsule also. Lot of adhesions are there. So we have operated 2 cases only till now, but many cases are lined. The patient has good vision, so we are not operating. We are waiting till the vision deteriorate. You just keep removing the adhesion by viscoelastic. As you see, the posterior capsule also very thickly opacification. Rotate the lens gradually. Again bring into the antechamber. Now, once the lens is antechamber, the work is very easy. So you have to protect the posterior capsule when explanting the lens from the bag. Now it is, in this case, we are giving a scaffold lens before removing it. So this is another way that you can put the scaffold lens before cutting the lens, because scissor might touch the posterior capsule. So you can put the scaffold lens first in place, and then you can explant the lens. Now we are holding the lens from the other side port, just holding the lens with a dialer and cutting the lens. A single cut. In this case, we are making a single cut and just hold the optic haptic junction, and lens will come out by simple rotation by 2.8 milliliter incision. So in this case, third case, so this is the lens removed. Now you can do, lens is already implanted, third case. This is another indication which is very common now in Indian hydrophobic lens, cut of the optic or haptic. This lens is implanted, case is successfully done. You see there is a breakage of haptic. We can't keep this lens inside the eye. Previously we used to keep it there. We were very afraid of taking out the lens, but dislocation of the lens is very common, and other doctor can pull your leg. So this is broken haptic at the optic junction. So you have no option but to remove this haptic first. And then this is hydrophobic lens. So it is not easy to cut by the scissor. So we are cutting, holding with the side port with the other dialer and cutting it through and through. Because it's hydrophobic lens, so it takes some time in cutting. And now the 2 pieces can be removed by the simple serrated forceps. You can do scaffold lens here, you can do lens implantation later on. So there are many techniques to remove the IOL. This is the scissor cutting is the one thing. Nowadays we are starting using the explantation of lens, not by the scissor, by our cartridge, which we are using snare technique. So we are cutting the lens by the snare, which was used long time back by our friends. Now we are using IOL cutting. So next conference I will show you that video. So we are cutting it to 3 parts, and then we can remove, you can make, because I am a SICS surgeon, also break the nucleus in the antechamber, 2 or 3 parts. So we can cut 2 or 3 parts and remove from the 2.8 millimeter incision. So next time we'll show you with another video with a snare cutting technique. This. Thank you. I'm well in time, I think.
Yes, you have saved us big on time. So any particular reason why you're not using a proper forceps to fix the IOL and the ballpoint dialer?
That is a blunt dialer.
There's a reason why I'm asking this question to you, sir. The reason why I'm asking this question to you is because particularly when you're cutting the hydrophobics, which are essentially harder materials in the fillix, and even the calcified IOLs make the IOLs. So when you're attempting to cut them, at times they just slip. And when they slip, they tumble. So one fragment faces the PC, the other fragment faces the endothelium. So
Anurag, actually we are holding the lens, we are just side port. it is only or not in large, it's very small. So forceps when go inside, you have to make big incision. But we are using nowadays with the micro forceps.
Yes.
We are holding with the micro forceps nowadays. These are all videos. We are holding with the micro forceps. But in hydrophilic lens, there is no use, no need to hold it. It easily cut because we have to cut only up to the center part, or not up to center, even up to the 1/3 of the upper part. Then you can take it out. But hydrophilic lens, definitely you need the support to hold it. You are very right. We are using micro forceps nowadays.
Yeah, the microforceps actually work very well for that purpose. The other question I wanted to ask you, sir, was since you are levering it completely out of the bag and keeping it in the AC, it's something I don't do. I actually tilt it and just keep half of it on the iris and half is still inside the bag when I cut it. Since you are placing it whole in the anterior chamber, are these patients operated under topical or do you give a peripheral block?
No, as practitioner, I will do the under the anesthesia because we don't know the posterior capsule what happening there. We need vitrectomy, we need something else because sometimes you posterior capsule not with, especially the second case when the opaque lens was there, we are not sure what is happening. That's why I implanted a sulcal 3-piece lens. You must have seen.
Yes, I have seen.
So we don't know what is going to happen. But the first case you can do in the topical. There is a very simple case.
Yeah, there's again a reason why I was asking that because the bulky haptics if rest on the ciliary body and if you're moving them while cutting them, they will move when you're cutting them. So sometimes under topical, the patient actually screams in pain. So a peribulbar would be a better idea. Thank you so much, sir.
Thank you.
Any other questions from the panel? We'll let you go, sir. Thank you so much for the pearls of wisdom. Chitra ma'am, can we take you now? In comes Dr. Chitra Ramurthy next, and she is going to speak to us on the prelex, the clear lens extraction, the tips, the options we have in hand for CLE as a treatment modality, of course, to correct refractive errors. On to you, ma'am.
A very good afternoon to one and all of you. Dr. Satanshu, you're not allowed to talk. So, good afternoon to our moderators on dais and dear friends in the audience. And the next few minutes, I'll be talking on clear lens exchange. Now, is it an option or is it not? You have a right to question me on that. But then, how we stand is, today we are doing the best as far as optical biometry is concerned. Yes, we could get better. We have diagnostics right from the dry eye to the OCT to the eye trace, every conceivable evaluation methodologies we have. We have the best of intraocular lenses, premium lenses, toric lenses, the EDOF lenses, trifocals, and enhanced monofocal. So there's everything there. And further to it, if you want to get ultimate, then you have the femtosecond laser cataract surgery. So it has not become vision restorative anymore, but it is vision enhancing. So how do we achieve this? For this, as I earlier alluded to, we need to be accurate in our biometry because you would have counseled those patients a lot and they have come to you for visual independence for all ranges of vision. You have to be able to choose the right kind of lenses for them. It has to be quality of vision has to be there that is free of spherical aberrations and chromatic aberrations to what extent you have promised them. The best of surgical techniques, the best of parameters, and of course, even post-operatively, if they are left with some residual surprise, you need to handle it. So it becomes necessary to have all of this, dedicated staff, equipment, technical guidance, to look for all those tiny variables in biometry and choose the best formulae, whether it's for a hyperopic eye, a myopic eye, or a post-refractive surgery eye. Now we have access to IOL masks. I've just taken one example. I'm sure others have good ones. But it has a combination of the swept source OCT and the B-scan biometry. Also has a facility to do the fixation check. So that all of these bring in that level of accuracy. Like how it does is, it uses both the swept source OCT and the B-scan biometry to measure the anterior corneal thickness, the posterior corneal profile. And what it does is, it measures on the anterior corneal profile and interpolates the information of the posterior cornea and gives us total keratometry or the total astigmatism. It has a 3-zone keratometry, and so multiple zones are measured. And this gets incorporated into the Barrett universal formula to become the Barrett TK universal or the Barrett TK toric. The only thing I want to tell you in the slide, which you should remember, is all the other formulas, they have their own mathematical formulae to make their calculations for the posterior corneal astigmatism, though they are not directly measured. So if you put the TK value into those formula, you might end up overcorrecting. That has to be kept in mind. So what you should do is, if a patient comes to reception wanting for a cataract surgery, goes to the optometrist, before the tear film is disturbed, it's mandatory that you do a biometry to understand whether there's a toricity there, and accordingly veer your discussion beyond that. You need to measure for both eyes. Even if the other eye is pseudophakic eye, it gives you a lot of information on the axial length, the keratometry, and if there is a variance between the two eyes, is it asymmetry between two eyes, or is it that the readings need to be repeated? It is also very important that we need to validate measurements. Like if there's a difference in axial length of more than 0.3, a K value of more than 1 diopter, or an IOL power calculation which is more than 1 diopter difference between two eyes, do not assume that the other eye is emmetropic, but you need to check the values. You need to ensure that the technician knows all the measurements, that the green light, that the standard deviation should not be more than 0.2 diopters of 30 micron, the signal to noise ratio should be more than 2. There are a whole lot of things which the axis difference should not be more than 3.5 degrees. So all of these which need to be you should look at those LED points. It should not have a fishtail appearance. They should be crisp points when they are being imaged. Now, in this particular case, you see the dark red shadow there. It could be an artifact. It could be just a Dellen or some kind of atropic pterygium there, but because of which the astigmatism measures differently when you retake the measurement, and then you find that it is far less. It becomes important for you to remember that in the keratometry, like if says that the standard deviation is more than 0.2, then is it dry eye status because of which you're getting errors? If not, you treat the dry eye. If it is not dry eye, you may have to wonder whether there's some keratoconus or there's a PMD. Do a tomography. If the patient has astigmatism, do go on to the toric IOL calculation. In other words, you need to examine right from the ocular surface to the retina and treat the meibomian gland problem that's there. Look at the OCT, whether the patient is fit for premium IOL, and then comes the decision whether it's trifocal or CRVO or EDOF or what you are going to do for these patients. So I'm going to run you through 3 examples: a presbyope, early presbyope, a hyperope, and a myope. So in a presbyope, what you can see is it's a small amount of presbyopia, but he wants to get rid of his reading glasses. And if you have access to eye trace, it gives you a lens dysfunctional index. And if it's from 0 to 10, if it's less than 5, it tells you that there is a problem there in the contrast sensitivity, the aberrations, the pupil dynamics are affected. And these are the reasons why this patient is coming back to you, and you could do well treating these eyes. And this was a patient who had a small amount of astigmatism in his eye. So we went ahead and took him on the femtocataract platform, did the astigmatic keratotomy also was done, and not going to go in great details of surgery, a gentle hydro. You can see how easily you can just separate the nuclear fragment and just engulf it at one go. It's just phacoaspiration, and the CD count is 0. So I'm not showing that, and finally he did very well. This is another way of doing it, is you need not do any softening at all. You could make 6 quadrants and then just bunch up the rexes, and then you could just do a hydrodelineation. Like I'm going to show you this. You could just do a hydrodelineation, and those grooves open up actually, and then you can just price apart these pieces and just engulf them, and that the surgery is done. So there's no trauma at all to the eye. You could do a flip technique, like in this particular thing. You can just inject hydro. It's very soft. It's not going to need any phaco power at all. And you just get the piece forward out of the rexes and bring it forward and just engulf it in no time, and then you go on to your cortical wash. If it is a high hyperope, like you could have done a phakic IOL, but you can't for a high hyperope, because if its AC depth is narrow and you can't do a corneal thickness is, high hyperopes, you would not do a laser procedure at all. I wouldn't do for more than a 3 diopter of hyperopia at all. So these are guys who are distressed with their thick glasses. So, but one thing you need to remember, these are high IOE parts. So because of that, there is a difficulty in predicting the effective lens position in these eyes. Again, these are short eyes. The anterior chamber depth could be normal or it could be shallow. And because the power is high, very small changes in the refractive error could cause huge refractive surprises. So in a high hyperope, you could implant a customized IOL, but you should be prepared that you're inducing spherical aberrations, or you could put a 40 diopter lens in the bag, and the remaining power you could use as a piggyback lens. So I'm not going to go into great detail, but you should see that the incision is not too posterior, your bottle height is elevated, you should ensure there's enough cohesive viscoelastic because there's less space in the eye, but you should not overfill the eye. You do not want too much fluctuations in the phacopower because these can itself induce a suprachoroidal hemorrhage in these eyes. So essentially, it has to be a very careful surgery in these very small eyes. And when it comes to a piggyback lens, for every diopter, you need to, in a myope, in 1:1.5, and this for a hypero. For a myope, if it is 1 diopter of residual error, you implant a 1 diopter of phakic IOL. But here, the patient had 6 diopter residual error, so 6 into 1.5, a +9 diopter of phakic IOL was implanted. So these come as a sulcoflex lens, which are large 6.5 millimeter optic lenses, which prevents any pupillary block or prevents glare. And these have undulating haptics, which sits well in the sulcus. And these have a concavity and against the convexity of the earlier lens. So there is no interlenticular opacification which can occur in these eyes. This is a case 3, which was a high myope and had a little bit of amblyopia. These are cases which I would never ever select at all, but if this person has very early cataract or has a dysfunctionless index, if you have examined his retina, it looks normal, and he's lucky that he has a posterior vitreous detachment already. If he has a staphyloma, you should do only optical biometry and use the very latest formula like the Barrett's or the Hill RBF formula. And as far as the surgery is concerned, it's a deep AC. So if you have the latest machine, you should see that the IOP ramp is high. You should keep your IOP value should be low. You should understand that could be a retropulsion syndrome or a reverse pupillary block kind of scenario can happen. So you should keep your parameters absolutely stable. And even if the iris is to go and hit on the lens surface and cause a reverse pupillary block, you could just go in with a Sinskey hook and just lift up the iris, and that itself would break the block. So again, and the other things, you could do multiple hydrodelineations, so it's easier to emulsify the whole cataract. You should do a good PC polishing in high myopes, and you might need a CTR in these very large capsular bags if it is a toric IOL. You should do a good PC polishing in all these cases, but I would avoid an anterior capsular polishing nowadays with toric IOLs. So again, if it's a low myope, you have to be very cautious. He's happy with his ability to read without glasses, so you have to be very, very sure that he would do well with a clear lens exchange. So ideally, you have to counsel a lot. It has to be the right patient. It has to be the right choice of lens which he needs. It's beyond the content of my talk to tell you how to choose the lenses. It has to be a perfect surgery. So in that kind of a scenario, refractive lens exchange is an important segment in our cataract surgery armamentarium, and you need to be choosy and selective and do your best for these patients. Thank you.
You want to ask something? Thank you so much, ma'am. Just wanted to understand from you, we all know that RLE is not something that we normally would prefer for a high myopic, but let's just keep that out of the equation. We're talking about moderate refractive errors here.
Yeah.
Moderate hyperopia vis-a-vis a moderate myopia, and we are doing an RLE. We are choosing a trifocal. Let's talk about the power that we should choose. We know that traditionally for a cataract patient, we would choose the first plus as the residual when we're choosing the right, when you're choosing a trifocal IOL. But would it change if we are doing it with an RLE for a moderate myopia vis-a-vis a moderate hyperopia? Would we still like to keep the first minus in the myopic and the first plus in the hyperopic, or would you choose the same residual spherical equivalence for both of these?
No, I would first of all never do a bilateral surgery. I would
No,
do
no,
the
even
dominant eye preferably first and make him emmetropic for distance in that eye and go. Then it is just that we do it in a week's interval, but people are coming from outstation, we do it in 3-4 days. And then when we do, before that, we do the refraction and try to understand whether he would need a little more myopia, then we give him a little more myopia in the other eye. Even though in a trifocal, you can implant the same power in both eyes, but we make these small adjustments in the, is that the question you asked?
My question was, say it's a 22.5 diopters and
Yes.
it leaves a plus 0.21 as a
Yeah.
spherical equivalence
Yeah.
is what we normally choose for a cataract
Yes.
patient. But for a moderate myopia vis-a-vis a moderate hyperopia.
Yeah.
If you're doing a
I
clear lens
would, I
extraction,
would like to leave him a little myopic if at all, rather than go onto the hyperopic side.
so that's for the
That's-
myopic patient.
yeah, yeah.
All right. And since you mentioned that you do not do bilateral surgery, which is of course the need of the
Yeah.
hour, but I mean we all understand the importance of it. How far would you leave them? What sort of a difference between the two surgeries would you leave?
Actually,
ideally?
there are so many simple, ordinary patients who come to us who get multifocal done in one eye, and I tell them to get the other eye done. They are so comfortable and they come back much later. So I don't think unless it's a type A kind of personality. But largely, 95%, 90% of our patients get one eye done, and when they come down after the theater to downstairs to see us, we fix the other eye right away, within a week's time, and do it off.
And if
So-
it has to be done bilaterally,
See, up to phakic IOLs we do bilaterally. Somehow bilateral we do not do in cataracts, but we have done on a second or a third day in those situations where people have traveled. But otherwise we let it be for a week for the refraction to stabilize, and it can always happen. Even if it is a monofocal, sometimes you might have rarely have overcorrected, though we feel, I'm sure all of us are feeling so happy with our results, with the kind of biometry and formulae which we have,
That's
that
true.
every patient
Right.
is seeing very well. But we keep that time interval. Maybe we are too conservative maybe, but we have been doing well in our practice with that amount of conservatism.
no, but since there's nothing to judge in form of the grade of cataract,
Yeah.
if the patient presents for an
in a-
RLE
in a-
bilateral, what?
Even if it is a clear lens extraction, I mean, 3-4 days is fine. It's okay.
No, but which eye do you take up first? Do you look at ocular dominance when you're doing an RLE in a
we
bilateral?
do look at ocular dominance.
And-
Although there are a lot of talks, I'm sure Gaurav also was there at ESRS, where they say that ocular dominance is not exactly
I don't
important
look at
at
it, so,
all.
yeah.
At all. But just like that, we go ahead and do it because, okay, we have to choose one against the other. So, what are your thoughts on it? I wouldn't mind knowing.
No, I don't look at ocular dominance at all, be it a cataract patient, be it an
No,
RLE.
not
I
in a
don't look-
cataract patient.
Even
in
in
a
RLE,
refra-
so if I'm not looking at it, even from the cataract perspective, RLE is much easier to decide. I don't look at the dominance at all. Nowadays, I've completely stopped looking at it. Any other points from anyone? Or, ma'am, may I ask you, is this your last commitment for the day?
No.
You've still got more. Thank you so much. We'll let you off then. We'll ask you to.
One point.
Meanwhile, can I just request Dr. Gaurav Luthra to come up? Ma'am, he has a question for you.
No, it's yeah. So I saw a case where you showed that the IOL power is plus 48.
Huh?
Plus 48.
40, yeah.
So one point which everyone should know is that these lenses are quite thick.
Thick lenses. So,
So you
you
will
need
have
to
to-
increase the incision.
Yeah. So
Yeah.
and also prefer that these cases should be done in the block.
Yeah.
Don't try to do them under topical because that can cause a choroidal effusion. So this is one point. And sulcoflex lenses, yes, these
Yes.
are other options if you are looking at a post-operative surprises in these cases, even after doing this. There's a new formula, or I don't know if it's there before. It's called as a Kane formula.
Yeah,
That
Kane
also
formula.
can be used, and this I've seen that this the formula which it gives is quite, the post-operative is very good. There's hardly any residual layer in that.
I use Kane formula for keratoconus patients
It
actually.
does, yeah. I
But,
just in the last 1 month I've done about 3 explants of ICL with cataracts, and it has given me a good outcome. So you can plan for that also.
Sadly, Rayner has actually stopped manufacturing the Sulcoflex. The Sulcofix is the only thing we are left with now.
Yeah. The care group has got it.
That's Sulcofix, so that's still there.
That's the only one now.
Dr. Gaurav Luthra just comes in with a name and a face and has traditional signature smile, and he is going to speak to us on cataract surgery in vitrectomy, gas and oil-filled eyes. Over to you, sir, for the next 7 minutes.
Hello. Thanks, Anurag, and it's nice to be in Vizag. Cataract surgery in vitrectomized eyes, they do pose challenges, and I get to do quite a few of them because we have an active VR setup in our place. So when it comes to cataract in vitrectomized eyes, there's been an incidence reported of 12.5 to 80%, and silicone oil seems to be one of the primary reasons, and gas tamponade the other. And then of course there is the occasional lens touch, and there may be PC feathering due to inflammation, and also lots of injections nowadays that we are giving. They're also inducing cataracts to many of these patients sooner than otherwise, and even it may change in texture of the cataract may change as well. The challenges are basically biometry, which things have changed a lot with the advent of optical biometry, and we, in our setup at least, for all patients undergoing VR surgery, they do get a optical biometry done before they end up going for the VR surgery, and also after they've been operated, because there may be changes in axial length with belt buckles and everything. So before they go on to develop a cataract, routinely our retina surgeons would get a optical biometry done, just in case somewhere in the few years that they go on to develop a cataract. There are also the retinal pathologies which have to be looked into. Sometimes you may have oil or gas in situ. You have to decide what kind of anesthesia you would like to use. These eyes will typically have very deep chambers. Many of them will be highly myopic. There is the possibility of zonal laxity, and the capsule may not be very healthy either, and there may be difficult nucleus handling. You may be dealing with a floppy iris, and sometimes you may have insecure wound closure because many of these eyes remain hypotenuse. So many of these challenges, and then with biometry, as I said, the belt buckle, and also the fovea may not be entirely easy to detect. So many of these patients have very poor vision, and there may be opaque media, there may be oil in situ, especially if you are forced to do an ultrasonic biometry. So there are several options. As I said, we can do it before and after VR surgery. A sitting position may help sometimes when there is oil in situ. You can adjust the velocity. B-scan helps, but as we've realized now, it doesn't come anywhere close to giving us an accurate outcome. And a fellow eye biometry may help, but as we understand, the axial length may change in VR surgery eyes. And then, of course, if you're totally at sea, you may consider doing this or coming back to do a piggyback, as was being discussed just now. So surgical challenges, they can be several. They may be coexisting glaucoma, oil bubbles in the chamber, endothelium may be compromised, rigid or floppy iris, difficult capsulotomy sometimes, and loose zonules. We've discussed few of these as well. So coming on to a couple of cases which I thought will make sense here. And you can see that a lot of oil there, which is okay. You can get this out just with pushing in viscoelastic. And once that is done, you can go and look at that peculiar cataract, and you can also see some silicone oil bubbles on the conjunctiva here. Sometimes they develop on the ports. And many of these patients, when you're operating under topical anesthesia, they cannot fixate well. So you may need to stabilize the globe. You can see there on the left, I'm using a globe stabilizer. And then, of course, once all that is done, things become much easier. But then there may be flotation effect. This eye has oil in situ. And you can see that, when there's oil, of course, some of it will keep finding its way from the zonules. And then also there will be a good flotation effect. And if you have to polish an eye with a PC plug, with oil in situ, it does pose challenges. While some surgeons would like to actually purposely do a posterior rhexis and drain the oil, I don't like to do it. It makes the surgery very unpredictable. The couple of times that I've done that, the oil sometimes comes out in, the size of the capsulotomy may be smaller, and then the oil may find it tough to come out. It may extend the posterior capsule tear in peculiar ways. So I don't like that route of bringing the oil out. I don't know if Anurag likes to do that, or anybody else over here wants to say that they like to do it that way. So once this is done, then of course PC polishing is good to do, because you don't want to do an early YAG in such eyes either. And meticulous, you have to spend time, you can manage, and then get away with a good surgical outcome in such cases. So there goes. It's good to keep maintaining the chamber all through, and I like to keep infusion on from my left port, so that if there is some silicone oil which is coming in from the zonular areas, it keeps draining out and doesn't preclude your view. So that done, the surgery is usually good to kind of, it's gratifying. Coming on to another patient with who rapidly developing cataract following VR surgery, and referred to us. You can see that the PC looked a little suspect here on the femtosecond laser. We decided to go with femto-assisted surgeries. Many times these lenses which are opaque will be seen nicely on the laser, which is the OCT on the femtosecond laser, and comes out that you can suspect if there may be a PC break here. And this is an intumescent, typical intumescent cataract. So once that is done, you can of course set it up. You want to stay away from the posterior capsule, you can change the posterior offset a little bit. You can see that this eye was gas filled, and the gas was still there. It was just 15 days after the surgery. This patient also had additional RK, multiple incisions, and had a rapidly progressive cataract, probably from a lens touch. So we were concerned about what may happen with the posterior capsule, and there was obviously gas in situ which was still to be absorbed. So femtosecond laser here was very helpful. Many people think that in RKIs it's not a good idea to do femto-assisted capsulotomy, but I like to do it. Even if you have some small tags of discontinuity, you don't get a runaway rhexis, and you can complete the rhexis. You can see the air bubble shining through there. It was challenging, and this was a fairly hard cataract. And the lady was very, very anxious and nervous throughout surgery because she had suddenly first had a detachment, and then after that she had developed a cataract. And so you can see the air bubble causing, the gas bubble there causing a lot of flotation effect. And I'm injecting in viscoelastic before bringing out my phaco probe. And there was almost no glow because of the effects of the air gas bubble there. Only when you tilt the globe to one side, you'll get to see the glow. So you have to operate without the benefit of retroillumination. And sometimes removing cortex in such eyes is challenging, especially with femtosecond laser cleaving the cortex just along the rhexis. It's sometimes challenging to do that. You'll probably just get to see when I move the eye to one side that posterior with retroillumination, you can get a view of what it looks like under retro. See there, I'm moving it to one side, trying to get a view, and then the air bubble, gas bubble comes back in, but you can check if you've left behind any cortex there. And once that is done, of course, then surgery becomes a little simpler, and you can go ahead and inject your lens. I like to use these preloaded lenses, like this one is the Hoya with the multi-cert, which doesn't require you to enlarge the incision, and you can inject the lens straight into the capsular bag. So in such challenging situations, and here I'm using this Herschel-Tuck cannula, which is really nice. You saw me hydrate the roof of the incision, the sides. In these RKIs, I like to do this. And you can see that in the left hand, I'm keeping the infusion on so that my chamber is always formed, and then going into the other incision. So it's quite a nice instrument, this, and it can, all 4 walls can be done, and then quickly check with trip and blue. So it is a little challenging, but can be managed. Do I have time to show one more quick 2-minute video? Yeah, okay. So this is actually a very short one. Here I'm trying to show that sometimes you'll deal with these silicone oil, cysts on the conjunctiva, and they can be irritating for the patient. Very easy to deal with. You just have to kind of make sure that you get a good, nice, deep puncture, and then with a bud or with something similar, you can squeeze out that oil, and patients do feel quite happy after this because they are unsightly and they also cause foreign body sensation all the time. So I typically would like to get them out. And so I think I'll stop here because there must be other speakers, and I'll finish off here with my last video. Okay, thank you.
Thank you so much, sir. I'm sure because of the shortage of time, you couldn't show even 10% of the plethora you must be having.
I did have a few more videos, but I thought, I've run out of time.
Tell me, talk to us through this. Usually these patients who've got vitrectomy done already, usually they present to us in a situation wherein the retinologist asks them to go for a cataract surgery. And by that time, you can have a host of situations. You can have the pupil non-dilating, but what is more important is if it's a very hard cataract, it's a dense nuclear sclerosis, and even the VR person is not able to tell you with concrete authority that there has been an instrument touch in the posterior capsule or not, what would you do? Or what would I do? Because I am a standalone practitioner. I don't have a vitreoretina assistance with me. So what should I do?
So one thing is that usually like my other patient where I thought there was a lens touch, but luckily we got away without anything going on. But I have dealt with a few patients where there was a lens touch or there was a suspicious thing because there was a rapidly progressive cataract. So there, you would have to use all the skills of one talk, which I heard you give in the other hall just now. Low infusion and low parameters, and I love to do that. I also operate around 30 to 40 bottle heights, and we have a master there who can fill in with us. Srinivas has just taken the mic because he wants to tell us something. He's the VR surgeon who can tell us a few things, but I typically would work at low parameters. I would always be prepared. I would be very careful doing a hydrodissection. Even if I did, I would probably do a hydrodelineation if it was a really soft one and create an epinuclear shell. So it's like it would probably work something like a scaffold, and I would just remove the central hard chunk of the nucleus first and then attack the, just like you do with a posterior polar pre-existing rent kind of a situation. That's how I would deal with it. And then of course hope that, and then there's been one instance which I'll never forget. I did a good capsular access, a similar cataract, went in with the infusion. These were the days like maybe 10, 15 years back when we used to work with 100 centimeter bottle heights. It was a high myope. The moment I entered inside and switched on the fluid, the whole nucleus went through and sank in 1 second. It was gone. So I think that's the benefit of using a low infusion and low parameters, and kind of inflate the chamber slowly, very gently, and don't let it suddenly expand big time, so that the lens iris diaphragm doesn't kind of go back suddenly. That can cause problems.
Fundamentally, what you're saying, I completely agree with you. But the only exception where I actually increase my fluidics a bit is the gas-filled eyes. I think they are
of course,
very
yeah.
non-compliant. They always keep pushing it forward, and
Agree.
you
But
have
that
to
you
have
can do during the course of the surgery. You'll realize that that's happening, and you have an intact posterior capsule, because otherwise the gas would have come out. And once you're sure that it's there, then of course,
Thank you so much, sir. We'll let you go. Yeah, Srinivas. You're the next speaker. Why can't you speak from the other row?
Here only
But
he's
you will
connecting.
use the same podium. All right.
Just one question I had. First of all, beautiful video you showed that when you are doing the cataract removal and the IOL implantation in a patient, especially who has a gas.
Yeah.
And
Right.
I didn't see any chamber collapse, nothing. It was
Absolutely.
just steady still as like a normal patient. My another question is, what was the urgency to do the cataract? So you could have waited for the gas to go away, or you could have even used a vent and put off the gas. If already the tamponading effect has been completed, then you can always put it a vent, remove that. It would have been little more easier rather than tilting and getting the reflexes.
Right.
But I should really admire, that was a beautiful surgery.
So this lady, as I said, she was a bureaucrat. She was very kind of anxious. She was anxious to get quick visual recovery. She literally pushed our retina team that following, she had, and as luck would have it, she had a rapidly progressive cataract for no reason. We didn't
So how did
understand.
you calculate the
what-
IOL
what
power in
happened.
that case?
We do optical biometry before we put up our patients for VR surgery as a routine.
So the-
All our refractive surgery patients and all our VR surgery patients get an optical biometry as part of their workup. So we had access to her optical biometry, and she was literally kind of, I was pushed to operate her on a non-scheduled day because she was not ready to wait for her cataract. Not that she would have seen anything after the surgery, because the gas would have still allowed
Still
her to,
there,
but
yeah.
at least
It's a long-acting gas.
sometimes you have to kind of cope with these demands as well.
So of the limited experience that I have, Srinivas, the urgency actually doesn't come from the patient, it comes from you guys, the vitreoretina guys who don't want to wait. But I completely agree with you, because both the anterior and the posterior capsules are virtually glued together, and he was implanting the IOL under BSS, so that makes it even better to behold. Dr. Srinivas Joshi, rumor has it that he has ordered for a fresh closet in his house to keep all the Rees Buckler awards that he wins at ASRS, and in fact, the ASRS has sent him an official mail request him not to participate in the award session anymore, because he's, I think, bagged almost a couple of dozens of it. I might be overstating a bit, but that's my habit, but he has won a lot of that. From Joshi Eye Hospital, and he, ladies and gentlemen, is going to present for the last time in this particular session before we disperse. And his topic would be the choice of IOL in the presence of retinal pathologists. Over to you, Srinivas, and we are waiting to listen to you.
क्या हो भाई? एक मिनट. Enter. इधर. Okay, good evening everyone. So the last I saw was India was 72-2 between the India and Pakistan match. Pakistan was 72-2 and India is playing well. The predictability is 68 versus 32 is what I saw it last time. Just wanted to give an update. So thank you.
Manufactured that, Srinivas. I'll tell you, we just manufactured that.
Yeah, so by the end you can again update the score.
Dr. Anurag. Thank you for that wonderful introduction. Thank you so much for that kind words. So I'll be speaking about how to go it. Okay. What's happening? It's not moving. Huh?
Ma'am, the
Okay.
whole conference is...
You're able to see this video? 1 second. Okay. So as we all know, the multifocal IOLs are often discouraged in the patients with or at risk with the retinal disorders. Diseases can include diabetic retinopathy, age-related macular degeneration, epiretinal membranes, and it's also believed to reduce the contrast sensitivity. But let's look into some of these videos. So this was the case where I was always telling that yes, multifocal IOL can be done and retinal surgery can be done in any case of multifocal IOL. So this was the case of bad retinal detachment in a case of multifocal IOL. Now you can see the PVR over the disc, and not just that, even there were subretinal gliotic bands as well. So I had to do a small retinotomy and then take away those subretinal gliotic bands. Do anywhere you see that there is blurring? No, I did not see. I did not see the blurring anywhere, and the surgery went very well. So I started advocating that no, multifocal IOL retinal problem, especially for the surgeries, it's definitely not a problem at all. Then recently I came around with another case where I had to do a epiretinal membrane, in this case of multifocal IOL. Now you see this, the round rings beautifully seen. So this was the case of IFIL grade 5, what we call it as. Now if you see here, yes, it was coming well. You see the ERM epiretinal membrane came very well. Now you see this ghost-like images. Do you see the forceps? Yes, it was looking blurred. So I had to refocus, focus again, refocus, focus again. So it took a little bit of time for me to do this. Now, this is my favorite where I try to do it in monochrome. That is a black and white technique where the blue visualization of the ILM comes very well. Now you see here I am trying to remove this. It was coming well, but again I had to refocus it because you can see those ghost-like images, what was said in the research papers. But surgery went well. It's not like it's going to be anything difficulty, but there is some difficulty. Yes, it is faced by the retinal surgeons with the patients with multifocal IOL. So this was the next, this is something called as the use of dark adaptation to screen before the multifocal IOL explantation and identifying the patients with early AMD to avoid suboptimal surgical outcomes. So this is something called as the ADAPT DX adaptometer, where it was approved in 2014, and it's test for the easy for technician. It can detect subclinical AMD at least 3 years earlier than it is clinically evident. Now let's look into cost effectiveness of pre-operative OCT in cataract evaluation for multifocal IOL lenses. I think it's a yes, yes, yes. There is no doubt about it. There is no controversy, no debate or anything. Any patient undergoing a multifocal IOL should get a pre-operative OCT at a must, because the OCT increase the detection of the macular pathologies and improve the qualis over the time. So let's look into these case examples. 61-year-old software engineer, bilateral drusenoid PED, right eye multifocal IOL. Now what to do for the left eye? Yes, you people have so much in the market, and you see, you do all, I've seen such a beautiful videos operating by all the cataract surgeons here. So what to choose, how to choose? IOL selection for the patients with age-related macular degeneration, the stage of the disease must be considered. Now, if you see here, patients without clinical evidence of macular disease, but like there is no drusen, no pigmentary changes, just having a family history is definitely not a contraindication. He's a normal patient, he's a candidate of all kinds of multifocal IOLs. Patients with early maculopathy, like patient who has soft drusen, pigmentary changes with relative sparing of the lens visual acuity, I call it as a difficult counseling. Not an absolute contraindication, not an absolute indication, but it's a kind of difficult counseling. But however, patients with moderate to severe AMD, where you see the drusens, large drusens with geographical atrophy or exudative changes already happening in those patients, then definitely it's a no-no for the multifocal IOL. The patient will be really, really very unhappy. Now, these are the pros and cons. I need not tell about all these things, but let's look into this. Would you implant a multifocal IOL in a patient with age-related macular degeneration? The author said that they are losing their independence, their ability to read. Often they are no longer able to drive or to engage in activities they love doing. Several articles have listed even depression as something not uncommon among the patient with AMD having the multifocal IOLs. Now, what is the lifespan of the people in India? Say around 60 years, now it's come to 70 years. Earlier, if now you see United States and Canada, it's almost matching. Now, why I am telling this lifespan, why I have included this into this picture? If you see the demographics of the wet AMD and the demographics of geographical atrophy, it's only 8.2% of the patient who actually undergo that is more than 80 years. And in geographical atrophy, it is 7% of the patients who are again more than 80 years. So the question debate arises here is, only for 2% of the patient, that is from 60 to 80 years if you catch, for 2% of the patient, why do you avoid putting a multifocal IOL in these kind of patients? So short-term outcomes, combined pars plana vitrectomy, epiretinal membrane, phacoemulsification surgery, it's all showing that yes, it can be done, multifocality was achieved. Scenario 2, wet AMD or geographical, if a patient already has a wet AMD with a multifocal IOL, definitely there is plethora, like how you people have intraocular lenses. The retinal surgeons have a lot of things into the market with a lot of biosimilars coming up, with a long-end technology biosimilars coming up. Now this is something interesting called as the nodal vision, which is the artificial intelligence called as the home-based OCT. It's the first of its kind artificial intelligence enabled digital diagnostic for the patients with neovascular AMD. So what it does, it takes around 10 pictures per day, and in case there is any fluid activity or anything, it pings the doctor directly, telling that there is an activity, and the doctor calls the patient, come back, take the injection, and then go back. So that's the kind of technology we are just entering through. AI-based nodal OCT analyzer successfully tracks exudative AMD. And then last scenario, if there is a bleed at the macula, then definitely biome versus contact lens is the question. Diffractive multifocal intraocular lens interferes with the intraoperative view, which I showed in the first two videos. These are the something which they call the arc-shaped images or the ghost-shaped images which are being seen. But how do we get out of it? Especially when you coat the anterior and the posterior surface of the IOL with a viscoat, then most of these effects are lost, is what is being described by the authors. And this is how you see pre, without having putting the viscoat, and post you see the right side using a viscoat, it does give a better view. So lastly, I want to quote this study, multifocal, by one of my senior colleague, Dr. Andrew Gibrowski. He said that we were unable to find evidence suggesting that the patients with macular disease should be advised against multifocal IOL. Several contraindications for multifocal IOLs in patients with retinal disease have a hypothetical character and are not evidence-based. More research is needed, especially to address the effects of the multifocal IOL on contrast sensitivity, visual functions, patients' activities such as orientation, mobility, and various other things. So thank you very much. I think these are few of the points which I just wanted to bring upon in cases with multifocal IOLs and the retinal pathologies. Thank you.
This is called people getting engrossed with the talk, Srinivas. They even forget to take your pictures till you're finished.
Thank you very much.
So essentially what the point you're trying to make here is the multifocal IOLs are not a no-no in the presence of macular pathologies, which might need treatment later on, either surgically or non-surgically. Is that the point you're trying to make?
Patients who have moderate, see that now the debate is normal patients who has family history, I think they are all like the normal patient. Now if they have a small drusen, now if they are the patient with hard exudates but no evidenced diabetic macular edema on the OCT, I have seen few of the surgeons telling that no, you are a diabetic, I don't want to give it. Okay. You are a diabetic, I don't want to put a multifocal IOL, thinking that it will cause trouble for the future, or telling that some retinal surgeons might have complained that doing a laser might be difficult and all those things. But now we have entered into the era of anti-VEGF modality, where the lasers, especially the focal lasers, have come down. Of course, the PRP is there, but when we put the contact lens with the viscoat, as I said, all those ring effects, what the diffraction which causes, I think that all goes off very well. I have tried it. That's why I showed the videos before. In one video, the peripheral visualization is absolutely no problem at all with the multifocal IOL. Especially when you want to do a very fine focus surgery like macular surgery or ILM peeling. In those cases, there can be a little bit of that images, what they described earlier as ghost image, arc-shaped images might come in. But definitely with the advancement in the visualizations, it's not difficult anymore.
No, but this whole thing is cocooned into the vitreoretina surgeon's perspective. Let's talk about the patient's perspective as well, because you follow them up more closely and more vehemently than we do. After cataract surgery, it always is the VR surgeon's chamber that we direct the patient towards. So how far have you seen patients complaining with regards to their vision, the quality of vision they receive after a multifocal IOL implantation vis-a-vis a monofocal IOL implantation? How far the quality of vision and how much of that would you attribute to the IOL that has been implanted?
To be very frank with you, in fact, I have seen many patients complaining who are almost having normal retina. They are the unhappy patients, like unhappy 6/6 patients, still telling that I am not seeing, I am seeing something else, I am seeing glare and all those things. To be very frank with you, retinal patients are very kind.
And why were those unhappy patients with a normal retina sent to you?
Because think that
Because
there
they
is a
were
retinal
unhappy.
pathology to look if there is a cystoid macular edema or pseudophakic cystoid macular edema or something like that. So that's the reason why. But I don't feel that there is much of difference nowadays. As of now, in the present day technology, of course, the multifocal can be, if you think that it's a difficult counseling, where I show category 2, in those cases you can try the extended depth of focus lenses
course
or
we can. We
less
have an array of
diffractive lenses, you can try those. I think those are the patients who will be really happy.
Any other questions? Any other questions from the audience? So we'll have, yeah, Dr. Sai.
Srini, as a retina guy, when you have a patient with silicone oil, would you prefer a hydrophobic IOL or a hydrophilic IOL?
You mean the silicone oil stays in that for longer time?
Yeah, the patient has silicone oil, he's come for cataract surgery. Would you prefer a hydrophobic IOL or a hydrophilic
we have seen
IOL?
with the hydrophobic IOLs only, but I don't see much of any.
What's your choice?
No,
We are all using hydrophobics only.
it's always hydrophobic actually. It's always hydrophobic because it doesn't allow anything to stick on the surface. So that's the basic reason why
Because
we
most of the
always
time these silicone oil are only for the temporary tamponade. Only very few cases, 2 or 3% of the cases in the retinal surgeries what we do require a long term or a permanent
I think
5,000
he
centistones.
meant that subgroup only, yeah. Right, if there are no other questions to be
Thank you.
asked, then I think we should sign off. Thank you so much, my coach. I have already given my talk. Thank you so much, ladies and gentlemen. I hope you all of you enjoyed the session as much as we did. And here's